So at this point, we would potentially transition to our keynote address. And we're very, very fortunate, as I mentioned briefly, to have Dr. Kathryn Schmitz, who is a distinguished professor of public health at Penn State University Medical College and the Penn State Cancer Institute, to help us with a very, very important emerging opportunity in the setting of lung cancer screening potentially. Dr. Schmitz has been working in the areas of physical activity for her entire career. She has been the president of the American College of Sports Medicine. She chairs the Global Exercise is Medicine Governing Committee. She's founded the Moving Through Cancer initiative in the American College of Sports Medicine. She has published more than 260 peer-reviewed science papers and has over $25 million in research funding since 2001. She has led a number of roundtables in the area of exercise for cancer survivor. She has co-chaired the International Multidisciplinary American College of Sports Medicine Researcher and Exercise Professionals. And she has been a driving dynamic force in helping us in understanding the profound impact of physical activity in the cancer context. And so it is with extreme anticipation that I wait to hear Dr. Schmitz's comments as we think about exercise for primary prevention amongst patients receiving lung cancer screening. Thank you, Dr. Schmitz, for helping us today.
Thank you very much. I am hoping somebody can give me a thumbs up that you see my slides and they're in presentation mode. Thank you. All righty. So I spend most of my time thinking about people who've already had a diagnosis of cancer. So Dr. Mulshine and I have had some fantastic conversations over the past several months for me to orient to your particular population. So as an overview of what I'm going to talk about today, we're going to start with talking about what we know, what the epidemiology tells us about exercise and prevention of the major chronic diseases, including potentially lung cancer. And I'll make a few comments about what the mechanisms might be that are pertinent, particularly for the conversations that you all will be having today and tomorrow. And then I want to talk a little bit about muscle and the importance of muscle, which matters a lot to patients in overcoming COPD problems, and review the musculature and COPD issues as seen on thoracic CT and how exercise can have an impact on this outcome, and what that might mean for patients that you all see day to day. But then I want to spend about a third to a half of my talk talking about implementation issues. I have been an exercise physiologist since the 90s, and as a result, I'm familiar with the idea that I can tell a group of clinicians that exercise is useful for their patients. And I know that at least some portion of the audience is thinking, yeah, but how is that going to happen? Because it's not a covered entity, and how do we make it happen? So we're going to talk about that. We're going to talk about the issues of the potential for implementation of exercise as a drug for pre-symptomatic COPD, heart disease, and lung cancer. As a source for the first section of my talk today, I am calling heavily on the U.S. Department of Health and Human Services 2018 Physical Activity Guidelines Advisory Committee Scientific Report. So this audience may not be as familiar with the fact that the U.S. Department of Health and Human Services has twice commissioned an expert panel from across the U.S. and a few people from Canada as well to come together to review the scientific evidence base and draw conclusions as to what the science tells us for exercise and prevention and treatment and rehabilitation of a broad variety of health conditions that are relevant to public health. And that scientific evidence base is then used to draw up the most current federal-wide guidelines for physical activity for all Americans, including those with chronic conditions. So one of the slides, and I know this is a little out of focus, but that was the best I could do coming out of that PAGAC scientific report. This is one of, I could have called up 10 different forest plots for you. This is one of many different forest plots about exercise and prevention of cardiovascular mortality. This particular one is about walking, exercise, and cardiovascular mortality, and it divides it by gender. So there's a section for men and there's a section for women. Interestingly, the answer doesn't differ much between men and women. When we take it all together at the bottom with a great big blue arrow on the bottom right-hand part of the slide, what you can see is a conclusion based on the available evidence base in cohort studies that have been done that there's a 30% reduced likelihood of CVD mortality for those who are regular walkers compared to those who are not regular walkers. I could have put up a slide that would show you this for swimmers. I could have put it up for joggers, for overall physical activity. This one was just as clear as the others. The evidence is really striking and compelling that exercise has an impact on reducing cardiovascular disease mortality. So this slide actually shows something really cool that I'm going to show you in an idealized form on the next slide. So what we're showing here on the left side is across the bottom of the slide, you can see the different net hours per week, which is just different levels of exercise. And I've translated the net hours per week for you on the right side of the slide. So you can see that there's a vertical line at 8.5 net hours per week, which is translated to 2 hours and 15 minutes of walking per week. And you can see that we have a substantive decline in ischemic stroke and ischemic heart disease, which is just underneath that ischemic stroke line. Almost 10% just from 2 hours and 15 minutes a week of walking. If we increase to looking at what happens at the level of 4 hours and 30 minutes of walking per week, which is not a crazy amount to ask people to do for prevention of these major diseases, we have a nearly 20% reduction in the risk of ischemic heart disease and ischemic stroke, as well as now we start to get to about a 5% decrease in a number of other diseases, including diabetes, colon cancer, and breast cancer. By the time we get out to 9 hours a week, we start to see some really substantive changes. So this particular slide is sort of pointing you to the idea of, well, okay, we want to do more physical activity. How much do I need to do? And my answer will always be, for what outcome? Exercise is a drug. It is a drug like any pharmacologic agent you want to give. As a result, it needs to be dosed. It needs to be dosed appropriately. We don't tell people to go get some chemotherapy. We tell them we're going to give them a very particular drug. We know what the action is of that drug. We give it to them with great specificity in terms of the dose, with body surface area, and the frequency with which we offer the drug. We need to do the same thing with exercise. It needs to be titrated. So this is an idealized version of the same slide that I just showed you. This was actually published in 1994. We've known this a long time. So Dr. Bill Haskell, who was a very well-known exercise physiologist at Stanford, published this theoretical dose response curve, which demonstrates the magnitude of benefit for any given increase in activity. So what we're really showing here, and what is most important to show here, is if across the x-axis at the bottom, you can see baseline physical activity level, and you see with A, we have a very low baseline physical activity level. And if we go from very low to not quite as low, so 10 minutes a day, let's say, of increase in physical activity in somebody who's a couch potato, look at the magnitude of benefit. It's almost vertical. Excuse me. Click that. It's almost vertical. On the other hand, if we are marathon runners and we're already doing 5 hours a week of aerobic activity, the increase, the relative impact of doing that extra 10 minutes a day of aerobic activity is very small. This is great news. This means that we get great benefit of physical activity for people who are very sedentary to begin with. Now, what does exercise have to do with, or physical activity have to do with the diseases that you all are particularly interested in? Well, I did find one case control study that was very specifically about COPD and showed that the odds of COPD were lower by more than 25% among the active versus inactive, and that breathlessness was much less common. The odds of breathlessness were lower among the active compared to the inactive. And importantly, this analysis, as you can see underlined in blue, was adjusted for cigarette smoking. But more importantly, perhaps, much larger set of studies were pulled together by a group that does an outstanding job of updating meta-analyses on a regular basis. This is a group out of Canada, and they pulled together the results of all of the cohort studies that had been done to that point in 2016, and all of the case control studies that have been done to the point that they published this meta-analysis. And the forest plot, if we look at the bottom of the forest plot, you can see with all studies combined across cohort and case control studies, including one of mine from 2006, you can see a 25% reduced risk of lung cancer among people who are more physically active compared to less physically active. And I'm just so curious. I wish I could sort of ask a question of the audience about whether you're surprised by that information. Anyway, so how would this happen? Why would we believe that there would be an effect of physical activity on lung cancer? And among the mechanisms, the one that I want to focus on today for very specific reasons is chronic inflammation. We have actually so many papers in this area that I've focused on a recent review that was published in this area that shows that if we are regularly physically active, a number of things happen. Things shift in a number of different tissues, including the muscle tissue, the adipose tissue, as well as in the circulation and blood vessels as well. And I want to point out to you the scale at the bottom showing that there is an anti-inflammatory phenotype that is adopted in the physiology of a body that is regularly physically active. But I will also very pointedly show you that in the adipose tissue in particular, as well as in the vessels, we show a decrease in TNF-alpha, IL-1, IL-6, and CRP. And I point those out in particular because if we then look at recent trials completed in canakinumab, the left side of this trial is showing the effects of canakinumab on prevention of incidence in patients taking different doses of canakinumab. But what's on the right side of the slide is important in light of what I just said in the last slide. And that is, in a separate paper, these same patients, there were analyses that looked at whether taking canakinumab had an effect on inflammatory factors. And the answer was yes for CRP and yes for IL-6. And these are two of the mechanisms through which we would believe that exercise would have an effect on reducing risk for lung cancer. So in addition to the fact that there is this systemic effect of being more physically active on the inflammatory process and sort of a pro-anti-inflammatory profile in the body systemically, there are a number of other things that happen as a result of being more physically active in anyone, including patients screened for lung disease. The first one being improved use of oxygen. Our arteriovenous difference in the blood is improved as a result of being more physically active. We do a better job of getting the oxygen to let go of the hemoglobin if we are doing regular aerobic exercise. Our energy levels go up, perhaps as a corollary to that AVO2 difference improving. Anxiety and depression are improved, sleep is improved, self-esteem is improved. All of these things are so well documented, it's difficult for me to find randomized controlled trials to show you of these because they've been known for so long. Cardiovascular fitness is obviously improved with regular aerobic exercise, muscular strength with resistance training, and very importantly for the populations that you all are talking about in the next several days, there is improvement in shortness of breath among those who are regularly physically active. We know in the populations that you all are dealing with on a regular basis clinically that muscle matters. Altered body composition is predictive of increasing mortality among COPD patients. And we can look at our thoracic CT scans to measure the muscle area for a number of different muscles that are found in the torso. And the figure on the right side of this slide shows you what survival looks like in patients with different amounts of surface or cross-sectional area, of erector spinae muscles, and clearly showing that patients with more erector spinae cross-sectional area have greater survival. The same can be shown for intercostal muscles and breathlessness. Greater intercostal muscles means better outcomes having to do with breath. Pectoris muscles are also shown in quartiles in mortality on the right side of this slide. What we can clearly see is that the patients who on a CT show greater amounts of pectoralis muscles in that CT survive longer among patients with COPD. Now, this was another place that was interesting for me because I've known, from I can get out my textbooks from the 1990s and tell you that exercise improves inspiratory muscle function. And so it was interesting for me to go find the papers in this area. And you can see that I'm quoting papers here from 1999 and 2002. This is something we've known for a long time. So it's time for us to start to put this into practice. We know that aerobic exercise, anaerobic combined with strength exercise improves pectoralis major strength. And on the right side, similarly, improvements in intercostal muscle strength as well. So with all of that in mind, we know exercise would help. We are aware of the fact that exercise would help, but it could be said that in the United States in particular, we tend to think of healthcare as being something that the doctor does for us, as opposed to something that the patient can do for themselves. And so how do we make exercise standard of care? How do we help our patients to help themselves? So the current state of implementation, as I understand it in your field, is that exercise is not standard of care in the setting of pulmonary screening for lung cancer, that a minority of patients are adequately active. And there are probably a multitude of reasons for this. These include lack of awareness by the patients as well as the providers that exercise could be helpful to them, lack of programming, or where there is programming, a lack of awareness of that programming, a lack of referral by the clinicians because of a belief by the clinicians that it isn't their job, that it isn't part of their scope of practice to refer patients to an exercise program. And then the question becomes, well, then whose job is it? There is also, even if we did get all of the patients referred, a lack of a well-trained exercise workforce that understands how to work with this particular population. And finally, we need to understand how to pay for this program, and it probably requires protocolizing it, much like we have with cardiac rehabilitation or with the diabetes prevention program. So let's talk through some of these issues, some of these implementation issues. So these themes, the themes that we see in the area of trying to change clinical practice to add exercise for this population would include certainly policy at a number of different levels, and I'll talk about that. Research issues, workforce development, program development, and stakeholder engagement. I will not have time to go through all of them, but I will point at a few of these. So at the level of policy and funding, at the federal government level or at the third-party payer level, exercise interventions require funding. You can't simply assume that everybody will be able to access and do exercise. on a regular basis without there being some kind of infrastructure. I am sure that if I were to query all of the people who are on this webinar right now, that there would be people who are having difficulty finding exercise time in their day and who would benefit from having a structure to make that exercise happen. Not to hold your hand, but perhaps to encourage you on your way. So how do we fund them? The first option would be to have all of the exercise delivered by healthcare professionals. So this would mean sending everybody to a physical therapist or an occupational therapist or a physical medicine rehabilitation doctor. There are possibilities of doing this, and there are patients for whom this is probably the best choice because they are that ill. But there are reasons why that is not a good idea. It would sink the ship with regard to trying to get an appointment. There are too many patients, and it would sink the PT ship. Another possibility would be to change policy so that exercise professionals who are working with clinical populations, like people who are being screened for lung cancer, for them to become healthcare professionals. This is a very, very long road, and there are pitfalls on that road as well. The third option that could be looked at would be to demonstrate that programs are effective in community settings and to change policy to cover the cost of those programs. The example for this would be the diabetes prevention program, which is offered by YMCAs and other private organizations. And the people who are delivering those programs are not healthcare professionals. They are being paid by third-party payers. They are being paid by Medicare and Medicaid, but they are being paid because they are abiding by a set of very particular rules and following a very particular script for how the program is done. This actually might be a way forward for the more well of the patients who come in for screening. Even if we have a program and we're ready to go and everybody's, the policies are in place, we have an issue with workforce preparedness, and I'll talk more about that in a minute. And in addition, referrals become a real issue in the area of cardiac rehabilitation and the diabetes prevention program, structured exercise training for peripheral arterial disease, a number of similar sort of programs or sister sort of programs to your situation. Referrals remain low. It's very difficult to get people to go to these programs. And so figuring out how to crack that nut and get referrals to happen is an important thing to do. There are also policies that are likely relevant to this situation at the level of organizations. For example, there may be accrediting bodies for lung cancer screening centers, and their standards may drive behavior. For example, in the setting of cancer care, the ACOS-COC, American College of Surgeons Commission on Cancer, accredits cancer centers, and they say that you have to be asking patients about psychosocial distress, and you need to refer people for care if you find that there's elevated distress. Then it happens. That didn't used to happen, and then ACOS-COC decided that it needed to happen, and now it happens. It happens at all cancer centers across the country. So is there something that could be done that would mean that it would be a requirement to recommend or refer patients getting screening for lung cancer to an exercise program in order to improve their health? I'll also note that in my own home organization, we have work to do. Pre-participation guidelines from the Guidelines for Exercise Testing and Prescription. This is a document that is used the world over on its 11th edition at this point, used by nurses and physical therapists, occupational therapists, exercise professionals in the clinical setting, all the way down to the YMCA to decide whether somebody should be working out in a clinical setting or in a community setting. Those pre-participation guidelines that are shown on the right side of my slide, I will note to you that they included, well, what do you do with somebody if they have known cardiovascular, metabolic, or renal disease? Well, there's not a word there about pulmonary disease. So even at my own home organization, we need to make some changes because at present, the exercise professional working in a clinical setting does not know how to triage someone appropriately if they have pulmonary disease. We need to do more research. Certainly, there need to be more efficacy trials to understand the benefits of exercise, to improve treatment efficacy, to improve health services outcomes. But I would also submit to this audience that we need to be doing evaluative trials as well, comparing the common implementation models, whether we should be doing counseling for these patients and sending them on their way, individual training, group training? Which one of these is the best model and most cost-effective model for us to move forward? There also needs to be work in the area of implementation science for us to understand how best to change clinical care so that clinicians working in this area understand who to turn to and how to press the easy button to make an exercise program happen for these patients. As an example of this, you could start with patients screened for lung cancer with CT scans. You would randomize these patients by clinic. So this is a cluster randomized trial. And you would randomize within clinic to a standard arm where everybody would be getting brochure therapy, which we have documented doesn't work, by the way. So handing people a brochure is not enough, as opposed to implementing an exercise as medicine approach where you would facilitate implementation to adapt a clinical workflow so that you would enable patient assessment, advice, referral, and connection to an evidence-based exercise intervention. By doing this, you would be addressing an existing gap in testing effective implementation strategies for improving physician referrals and utilization of evidence-based exercise interventions in the setting of lung cancer screening clinics. We know that this evidence base exists for short behavioral interventions, referrals, and treatments, in primary care, but there is a gap in the setting of lung cancer screening clinics. It's also really, really important that we do this work in the setting of community clinics and not just in academic clinics. And the reason for that is that it's important to study real-world factors that influence implementation. This is, of course, a multi-level intervention. The first level of intervention is something that we think of when we think of randomized controlled trials, and that's the level of patient. That's the evidence-based exercise intervention. But there also needs to be an intervention at the level of the treating clinician and the care delivery team. There needs to be a change in how the clinic is doing business in order to change getting exercise to be a part of the clinic flow. Specific aims of a trial like this could be to assess whether or not doing this implementation facilitation, this implementation work, actually increases the proportion of patients that actually get referred to an exercise program. And the second aim would be an implementation aim to see what the mechanisms are for making that happen. What are the, what's making the gears turn? And then the third aim is about the effectiveness of the actual patient intervention itself. There is, of course, a need for workforce development. Again, if we were to get all the money in the world and all the policies in the world to happen tomorrow for this, we still don't have a workforce that is ready to work with lung cancer screening patients. We need to identify the knowledge, skills, and abilities that are necessary in exercise professionals to work with lung cancer screening patients, and probably rebuild some kind of credentialing tool at an organization like the American College of Sports Medicine, and perhaps create something like a one-on-one module. My reasoning there is that it is likely that there is a great broad variety of impairment in these patients. And in the same way that you don't need every YMCA floor trainer to be ready to do cardiac rehabilitation, but they all need to know how to do CPR, and they need to be able to screen people and say, you shouldn't be here, you should be a cardiac rehabilitation. We need people to know when they should stop working with somebody and send them to a more clinical setting. And that's what that one-on-one module would be about. Finally, there needs to be program development. We need to identify the places around the country where programs already exist. There are likely exercise programs that are exemplar programs. Map them, figure out where they are, who has them, why do they have them, and somebody else doesn't. Enlist a national fitness chain to perhaps start pulmonary specific programs. There are enough Americans around that have this issue that they may actually make a buck on it. And finally, by mapping them, you can help existing programs to spread. So what I'm concluding here is that in order for you to take the evidence base about exercise and pulmonary disease and translate it into clinical practice, there is an entire field of research that needs to happen in implementation science for that to all shift. It relates to policy, stakeholder awareness, program development, workforce development, and research. Thank you very much.
Thank you so much, Dr. Schmidt. That was wonderful and incredibly relevant to our workshop discussions. I've already seen a question from Bruce Byenson regarding your presentation. Bruce, do you want to talk about that?
Yeah, thank you, Jim, and thank you very much, Dr. Schmitz. Wonderful presentation. There's some prominent organizations that are in the wellness space, or used to be called disease management space. Examples of those organizations are Livongo or Unduo, which is a subsidiary of Google, I think, and those organizations sell programs to employers for as part of benefits program or to insurers for the insured populations. I'm wondering if you have a perspective on the effectiveness of those programs for the kind, given the evidence that you presented and the compelling results. Welcome hearing your thoughts on that.
Yeah, I actually think that has worked quite well for the diabetes prevention program. And I think that one of the things that I think has gone well with that is that payers are able to hold those companies and others like them, hold them to standards. If they only get paid if the patient shows up more than 5 times, and they get paid more if the patient loses 7% of their body weight or something. So they're very outcomes oriented, and they're held to a much higher standard than most of the rest of healthcare. By the way, I love that idea.
Thank you very much.
Thank you. There was wonderful opportunities from your description of changes in the musculature as a function of fitness and whatnot. Dr. Yankelevitz, who is an imager, as you well know, has some questions, I think, in that regard.
Yes.
Hi, Kathryn. Actually, Jim, I had a couple of questions. First, as a comment, I really appreciate the idea of thinking about exercises in terms of being a drug and thinking of dose. That's really I hadn't heard that before, and I appreciate that. And I do have a question about how you decide the dose, given, that's one question. And then the other thing I just was hoping you could comment on, since a lot of this is about lung cancer, I know there's been a fair amount of work on the benefit of exercise in cancer patients, and in particular, both in predicting prognosis, looking at the general health of a person and exercise preventing recurrence, and also potentially in sort of treating disease. But since we're a stage 1 group that we focus on early lung cancer, how do patients that get lung cancer, preventing recurrence, how well they do, that sort of thing. Do you have anything that you might add to that?
Sure. So let me answer your first question first, because it's an important one. And your question was about how do you figure out the dose? And the answer is in dose finding studies. Those studies exist, and we are able to titrate and understand how much exercise we need to do for a broad variety of different outcomes. And the roundtable that I spearheaded for the American College of Sports Medicine on exercise and cancer prevention and control was able to conclude that we had sufficient evidence to give a what we call a fit prescription, which is frequency, intensity, time, and type, which is about as exacting a dose as you can get for 8 different cancer health related outcomes for people who are going through treatment and soon after treatment. So those studies do exist. And if they don't, then that needs to happen for you to figure out exactly how much to titrate. And I would submit that we go for maximum tolerated dose, right, in a drug study. With exercise we kind of turn it upside down because, exercise is like broccoli, nobody wants to do it. So, so we've got to figure out the minimally effective dose, because that's what people are willing to do. So, but your second question was about what we know about the benefits of exercise in early stage lung cancer. And the answer is really little, really little. That is actually an area that is very ripe for additional research, because we have no reason to believe that the benefits, the 8 cancer health related outcomes that are better during and after treatment, those data are available, based on studies that have been done in colorectal cancer and breast cancer and prostate cancer and many of the more common cancers. But there is absolutely no reason to believe that it wouldn't be true in early stage lung cancer as well. But sure would be better to do those studies, even if it's a demonstration project, just to say, yep, it's the same. Okay.
Do you have other people that have questions?
Yeah, this is Al Rizzo. Dr. Schmidt, thank you very much for your presentation. I'm a pulmonologist and I work a lot with the American Lung Association. And quite honestly, since 1980s, we know that pulmonary rehab has been shown scientifically to benefit patients with COPD. And we have had the fight with really the third-party payers, the government, to try to get pulmonary rehab supported to the level that it needs to be. I mean, the amount of money they throw at it doesn't allow for centers to be up and running, doesn't allow for the staff that you're talking about.
Yep.
So I'm glad you're going to add something to your sports medicine thing about pulmonary that you mentioned that would help. And I'm curious as to whether you've ever been enlisted to be on some of the advocacy teams to address the issues about the importance of exercise and lung disease, particularly pulmonary rehab.
Not yet, but I have a feeling I'm about to be enlisted.
Well, yeah, we work a lot with the AACVPR about pulmonary rehab and cardiac rehab, and we just keep hitting a brick wall. So I'll look forward to maybe connecting with you and seeing what other ideas you may have, because this is just frustrating for the patients, it's frustrating for the physicians, and therefore the referrals don't take place because we know it's not going to happen. It's not paid.
Yeah.
So you hit all the topics.
I suspect that, and this was exactly Jim Mulshine's nefarious idea to get me involved here. So he's like, what? I don't know. Anyway, so Dr. Rizzo, I based on my reading of the literature, I suspect that exercise for cancer patients during treatment is in a very similar place to exercise for pulmonary patients. And that is that we have this gorgeous evidence base, and yet it doesn't happen. And so there is a need to shift our attention so that, if they're not paying for it, or they're not paying for it sufficiently, then we need to give them a different kind of evidence. There's clearly a need to shift so that we're focusing on this implementation science and health services research. And I've thought that was the case for pulmonary disease and exercise for a long time. So I'm in. Count me in.
Great, thank you.
Am I allowed to call you Bo too?
Yes, please. Anyway, so that was a great presentation. It really, really highlighted some of the things this foundation has been saying for years, although we haven't been specific to cancer patients. We've been more about the benefit of exercise when it comes to primary prevention. But what I wonder in practical terms is whether the group of lung screening centers that participate in the GO2 Foundation's Centers of Excellence program that have been certified as Centers of Excellence, and there are 900 of them around the country, if there could somehow be a demonstration project, that's something this foundation could consider funding within a certain.
And it could be virtual. It doesn't need to be in person. We now because of COVID, the gift of COVID,
even better,
is that we all are understanding that we can be with each other virtually. And most of my trials, even particularly like I do work in metastatic breast, and we're not seeing those in person. They're at risk,
sure.
So we're doing a lot of exercise trials virtually, and I think that there is a lot of room for that. So I'd be very, very interested in talking to you further.
Well, we should talk to Laurie Fenton Ambrose and see if there would be any interest in the GoTo Foundation's part in doing some sort of demonstration project. I don't think that there's an exercise component required for one of their centers to be certified as a center of excellence. So
Right.
it seems like, but you've got a group of screening centers that we know are doing a good job, and they've
Yeah,
passed.
would be interesting to start with a survey of those centers to find out who's doing exercise.
It would be. It would be. Well, but that's a next step, isn't it, Jim? Between now and next year,
Yeah.
next week.
That's right.
Thank you.
Absolutely.
Yeah, Kathryn, I think this is a wonderful set of discussion that emerged. One thing I would caution though is Bo talked about this as a preventive service. And I think in the setting of screening where we potentially screen 100 people, one of them on a given year may have lung cancer. And so in a sense, it's better, we need a new term for people participating in screening. They're not really patients. They don't have a disease, they have a risk of a disease.
Mhm.
And the concern is that they would start thinking themselves as patients, and that's the kind of antithetical to what we're trying to accomplish. We want to be healthy people, and with the risk that we can manage the risk. And so there's a whole.
Yeah, as a corollary, I'm on the standards committee for the National Accreditation Program for Breast Centers, and I am advocating pretty vigorously for the idea that women who come in for a mammogram should be given something that tells them what else they can be doing to reduce their risk of breast cancer. And so we have that now in standards. That's going to be rolled out next year. So could we? I mean, I'd be delighted to hand the same thing to you all, because the risk reduction guidelines are risk reduction guidelines regardless of, I mean, there's quit smoking, get a healthy weight, exercise, eat a healthy diet, I mean, they're the things that I think everybody on this call knows, right? But ACS has produced beautiful graphic things that could be handed. I mean, we need to do more than, you have to do more than hand a piece of paper to people, but handing a piece of paper to people is a start. By virtue of the centers doing screening, handing a piece of paper, the centers acknowledge the importance of the patient's behavior to their own health.
Mhm.
Just simply by virtue of getting them to do that, it's a step. It's a step towards having a program.
Yeah, so we should do, ACS is the sponsor of this workshop, and we should follow up with them as well. So we have action items for both them and GoTo Foundation. It was interesting, your comments on the biomarkers of inflammation that were modified by exercise and how they overlapped with the intermediate endpoints that they used in the CANTOS trial that you described. And I understand from some of the discussion of that, and George Washko will be with us later, one of the concerns was that the imaging done in the setting of that cardiovascular and lung cancer secondary endpoint trial were not specific towards COPD, so that if there was a benefit of modifying those inflammatory mediators, it wasn't necessarily appreciated in the lung parenchymal imaging, because the lung parenchymal imaging wasn't done with a clear definition of what's good and what's bad. And it kind of reflects the state of the art in lung cancer imaging, that we can tighten up stuff so that the experimental signatures can be reduced into clinical practices, and we'll have more comment on that. But the again, the issue of trying to figure out if in a particular individual, if we could map the state of their various muscle groups, and potentially their fat depositions and other body composition factors from the quantitative imaging, and have a snapshot on an annual basis and say, Mrs. Jones, you're doing a great job with your exercise program, and your fitness profile along the lines of what we use for a BMI, but the BMI doesn't work because it's too non-specific. Whereas we have this possibility with the imaging profile to be much more tailored in giving a meaningful objective basis for whether their dose of their exercise drug
Is
is
not,
sufficient or insufficient or being followed closely enough. I think that would be very helpful in a clinical setting for a whole variety of reasons. David, do you want to comment on that? You've done some background work in that regard from your group, right?
Yes, we have, and there's a lot we can measure. There are a lot of indicators of muscle mass, muscle quality, fat quality, and potentially, even more that we can do. So this would be of some interest, and especially in the screening context where you are bringing people back at annual intervals, you can look at change over time. I don't know. I was curious though, Kathryn, how do you measure progress? How do you measure whether people are progressing in terms of their exercise? Do you measure sequentially levels of inflammatory markers, that sort of thing?
no. We look at pretty gross measures of physical function tests. I actually, over time, have migrated away from doing structured exercise testing because what I get from it clinically is not so much better than doing a short physical performance battery, a 6-minute walk test, chair stands, those kinds of functional tests, and then body composition. We know the body composition changes as a result. I mean, if we have,
how do you measure body composition? What's your
our preferred
traditional
measure
technique?
for in the clinical setting is DEXA, and I understand the limitations of DEXA, but that's what we use.
Just one other question. Usually when people talk exercise, they talk a lot about diet. And I noticed in your talk, you didn't focus so much on diet,
Right.
especially, and even in the context of lung cancer. I know this is all very controversial, things like diet and how that impacts, but emphysema or lung cancer. How much weight do you give to the role of diet and the impact of diet in some of these areas?
Yeah, so it's a tricky thing for me to talk about because I know what the science says, and at the same time I'm not a nutritionist, so I'm an exercise physiologist. So what I can tell you is that the science on the effect of exercise on the pulmonary system and systemically in ways that are relevant to the pulmonary systems, the cardiovascular system, and musculoskeletal system is deep and profound. And what we know is relevant clinically and actionable right now. But you don't have to exercise. You can go your whole life and not exercise, right? But meanwhile, you do have to eat, right? So you actually do have to eat, and so people do want some kind of guidance about their food, but the scientific evidence base about the effectiveness of various different diets on pulmonary outcomes, musculoskeletal and cardiovascular outcomes is not as robust as it is for exercise, in part because it's more complex. I'm not criticizing my colleagues, it's just harder to do because there's so many more variables. I think that what we are able to really kind of, put our thumb down on and say, yep, we know this, is more fruits and vegetables, limit red meat, and generally avoiding saturated fats. What we know is relatively small, and we don't know, we're not able to do the dosing. Diet is a medicine like exercise, but our ability to dose it, we're not there. We're just not there. Sorry.
Do you have any more?
Any other questions? Bruce? oh, okay. We have a question from Stephen Lamb. Are there nomograms for erector, spinalis, pectoralis, and intercostal muscles? Does that
No.
make sense?
No, but that could, I mean, based on what David's got, I think it could be developed.
Yeah,
That's provocative.
and that would be very important normative information in terms of
Right.
developing an annual fitness type of thing. One of the questions that emerged in my mind relative to, so you have a motivated individual and they get in an exercise program and they're doing structured exercise, however it's defined. I gotta believe that that person might be a more appropriate candidate for tobacco cessation efforts. Because, you know, they're starting to focus on their health and realizing the implications. And in general, athletes smoking is not as prevalent as non-athletes smoking and this, that, and the other. Have you ever thought about that relative to your work with cancer patients?
Yeah, I actually thought of doing this as my dissertation. It's just so funny because this is something that's like been in my head for a long time. Harry Lando is a tobacco researcher at the University of Minnesota where I did my dissertation. And I was interested in this idea. What we noticed in the heritage family exercise study was that the smokers shifted who were instead, they had to come in 3 times a week and do really high intensity exercise 3 times a week for increasing amounts of time over 20 weeks. And what we noticed was that the smokers changed their practice of smoking and their timing of their smoking according to when they were going to exercise. They would avoid smoking prior to doing an intense exercise session because it was so uncomfortable, right? So I was just fascinated by that and thought, that would be very interesting. There has been one successful pilot that looked at physical activity for smoking cessation that went very well. And then they did the fully powered trial and it did not go well because they couldn't get people to do, and this was interesting to me in light of my observation all those years ago, they couldn't get people to do the vigorous intensity activity.
They couldn't do what?
Vigorous. They couldn't get them to do vigorous, high intensity activity. So, I think that I think that it's an issue that could use some more attention.
Okay.
But I think it needs to get attention at a level of like, a pilot and some qualitative work, at this point to understand what smokers are willing to do. I think, I think it's worth chasing.
Okay, well, thank you so much. And we have to conclude now, but it has been so wonderful hearing your thoughts on this very, very important subject and important opportunity. And we will follow up with suggestions that we just discussed. So thank you, Kathryn, for a wonderful keynote presentation.
Well, thank you so much for the invitation, and I hope that the rest of the time together is productive. Maybe I'll be back to present some results next year.
We look forward to that.
Okay. All right.
Thanks.
Okay. Bye-bye.